Well, hello and welcome to the Haldeman Norfolk Health Unit Special Board of Health meeting for July 7th, 2020. I'd like to remind everyone that our meetings are web streamed and televised, and for those in attendance, if you could please put all your telephones on silent mode. Okay, good. Reminder for the Board of Health, we do have a public hearing committee that's scheduled for 3, so hopefully we can wrap up by then. If not, we'll have to recess and we'll begin our public hearing committees and then reconvene the Board of Health after the public hearings. So to begin with, changes to the agenda. I have a motion that's been moved by Board Member Martin and seconded by Member Geisens that the agenda be approved with the following amendments: addition of communication item, that's 7 alpha from Jason Burgess regarding the Agricultural Advisory Board's position on preferred practices with COVID-19 and management's response. And then as well, the Deputy Clerk just omitted it from the agenda, but just any other business will be at item number 11. All those in favor? Carried. All right, any disclosures? Member Michele, go ahead.
Thank you, Madam Chair. I'm wondering if, before we get to that, if I could ask to have consent item 3A pulled for a brief discussion.
No problem. We just have the one item, so I think you'll be all right.
Thank you.
Any declarations of pecuniary interest? Okay, seeing none. Moving on to the consent item then. Member Michele, if you'd like to go ahead.
Thank you, Madam Chair.
My apologies. I see now there's a note here that staff had requested that it be moved to item 8B, so if we could deal with it at that time.
Okay, thank you.
Okay, moving on to the adoption of the Board of Health meeting minutes. We have before us the open and closed session special Board of Health minutes from June 30th. Are there any errors or omissions? Okay, seeing none, they'll be declared as adopted, signed by the chair and county clerk and affixed with corporate seal. No deputations today. So moving on to 8 alpha. Shanker, I guess that's over to you for your update.
Could I get a clicker?
Oh, I'm sorry, Shanker, I jumped ahead here on you. I guess they wanted to do HSS 20-04, the social determinants of health. My mistake.
It appears that there's a sound issue. Staff are all at GAB this afternoon, so I think they're just trying to work through that technical challenge.
We weren't able to.
Okay, if I'm not sure who's presenting, but whatever staff is out there.
take
Oh, you're going to present, Marlene?
Through you, Madam Chair, the staff at GAB are going to present. So for staff report HS 20-04, I'd like to introduce Alison Dunn and Margot Fournier, who are two of our public health nurses, and they're going to present the report on the social determinants of health, if that's the one we're starting with.
turn the slide. No, take control. Cross our fingers.
Ms. Dunn and Ms. Fournier, if you're ready to begin, you can go ahead.
Okay, thank you. Hello, my name is Margot Fournier, and this is my colleague Allison Dunn, and we are here to discuss and provide you with some information on the social determinants of health. Income is probably the most important social determinant of health. It not only influences health behaviors and psychological functioning, but it also determines an individual's overall living conditions and impacts on the quality of other social determinants of health, such as housing and food security. Research has determined that in any given society, those with a higher income do better on a range of health outcomes. Therefore, a social gradient in health means that for every step up the socioeconomic ladder leads to an increase in health. In 2019, the Hamilton Spectator, in collaboration with researchers from McMaster University, published a 10-year update on their Code Red series. Researchers found that less affluent neighborhoods were 5 times more likely to not have a family doctor, had 2 times higher rates of ER admissions, 4 times higher rates of urgent hospital admissions, and 9 times higher rates of ER psychiatric visits. Income inequality, or the degree to which income is distributed unevenly throughout a population, also impacts on the health status of individuals and populations. Income inequality has been linked to differences in health outcomes, such as life expectancy, infant mortality, hospitalization, and mental health. Research has shown that countries with greater income inequality have worse health outcomes. The low income measures at 2014 show that Haldeman Norfolk's overall poverty rate is 11.74. However, some towns, their poverty rate is as low as 5, where there are other communities with poverty rates that are 16.8, 17%, and 21%.
In general, good paying jobs makes it easier for workers to live in healthier neighborhoods, buy more nutritious foods, and provide good quality education for their children. All of these impact health outcomes. Also, good jobs tend to have good benefits, and that impacts on the health status of individuals and communities. Research has found that higher earnings translate to a longer lifespan. According to the 2019 Hunger Report, food banks are seeing an increased usage in their services by individuals who are employed. Although social assistance users are still the largest group accessing food banks, there has been a 27% increase in the proportion of people who are employed and still accessing food bank services. Low income and insufficient work hours were the primary reason given for accessing food banks by individuals who are employed. The report also examined our changing labor market, and what they found was that whereas in 1988, the majority of people who were working in minimum wage jobs were youth in high school, now nearly half of all minimum wage earners are 25 years of age or older. And of these workers, nearly 1/3 have a post-secondary degree, and almost half are working full-time. In 2019, the United Way of Haldeman and Norfolk calculated the living wage in our counties to be $16.58 per hour. A living wage is considered to be the hourly wage a worker needs to earn to cover their family's basic expenses such as transportation, food, housing, utilities, and childcare. Current Ontario minimum wage is about $14 an hour, which seriously falls short. As well, working in a job that has poor working conditions has detrimental effects on health outcomes. People who are already most vulnerable to poor health outcomes due to their low income and education are also the ones more likely to experience these adverse working conditions. In fact, about 30% of Canadian workers feel that their employment puts their health and their safety at risk.
Employment provides income, a sense of identity, and it also helps to structure day-to-day life. Unemployment frequently leads to material deprivation and social deprivation, psychological stress, and adoption of health-threatening coping behaviors. Lack of employment is also associated with both physical and mental health problems, such as sleep deprivation, high blood pressure, heart disease, depression, anxiety, and increased suicide rates. Unemployed people face numerous health challenges beyond the loss of income. They are far more likely to have fair or poor health and to develop stress-related conditions such as stroke, heart attack, heart disease, or arthritis. Along with a number of people working in minimum wage jobs, we're also seeing a rise in precarious employment. Working in involuntary part-time employment, working on contract, or in temporary or seasonal work, and being self-employed are all forms of precarious work. A 2014 StatsCan labor market study determined that nearly 1/3 of Canadian working population were in unstable employment. The RNAO reported that lack of decent work and living wages is taking a significant toll on the health of workers and their families. People who are precariously employed are at double risk of diabetes, 2.5 times more likely to experience fatal occupational injuries, and have a 40% higher risk of heart disease. And in comparison to those in secure employment, are almost 55% more likely to report that they are depressed as a result of work.
In Canada, we have programs and services that support individuals and families that go through changes in their lives. These supports are collectively referred to as our social safety net and include things such as social assistance, unemployment insurance, pensions, and health insurance. Ongoing challenges have been identified with these programs. For example, social assistance rates have not been increased with inflation, so are insufficient to provide to cover essential costs such as nutritious food, safe housing, utilities. For employed individuals, there have been changes to the WSIB and EI programs and have weakened these systems. 46% of injured workers with permanent impairments end up living in poverty 5 years after their injury. As well, with the rise in precarious employment, only 40% of Canadians are actually eligible to receive EI benefits even though they've been paying into them. These gaps in the social safety net can lead to a lack of income, which in turn leads to poverty and overall poorer health outcomes. And the final social determinant of health is that of food insecurity. Household food insecurity means that a household has inadequate or insecure access to food of adequate quality due to insufficient income. Food insecurity is a major public health concern as it is associated with inadequate nutrient intakes, poor mental health, and increased risk of chronic disease such as heart disease, hypertension, and diabetes. Nutritious Food Basket reports demonstrate year after year that a nutritious diet is unaffordable for our vulnerable populations in our communities who live in low income. Of households whose major source of income was social assistance, 61% were food insecure. However, it's not those just on social assistance who are vulnerable to food insecurity. 62% of food insecure households rely on wages or salaries from employment. According to the Canadian Community Health Survey food security model, 1 in 9 households in Haldimand and Norfolk are food insecure.
And in closing, we would like the Board of Health to have a better understanding of the social determinants of health and their impact on health equity. And this will enable the Board of Health to advocate for and support the development of healthy public policies that facilitate health through the reduction of health inequities. This report provides the Board of Health with information on how income as a social determinant of health impacts the vibrancy and creativeness of the community. In acknowledging and educating our community on the effects of income and other related social determinants of health and the health outcomes, it provides us the opportunity to begin the important work of advocating for public policies to support those that are most negatively impacted by these determinants. We would like to thank you for your time, and we will take any questions now.
Thank you, Allison and Margot. Any questions for staff? Okay, Member Van Passen.
Thank you, Madam Chair. Staff want the Board of Health to lobby for better government programs. Are you referring to better education and training for people so they can actually get better jobs, or what type of programs are we expected to be lobbying for?
Madam Chair, through the chair, I'm unsure which councillor asked the question, but there are many public policies that we can advocate for. Education is one, because again, a lack of education does impact on one's ability to obtain a job and keep a job. So there are, other ones that we can focus on around nutrition, transportation. So there's lots of barriers that people with low income have to overcome to meet their health needs.
Member Columbus.
Thank you, Madam Chair. Mike Columbus here. Just the question, your report mentions that 1 in 9 households in Haldimand and Norfolk are food insecure. Do you have a breakdown between Norfolk and Haldimand on what that would be?
Through the chair to Councillor Columbus, unfortunately, we don't have that breakdown. We do have dietitians at our health unit who are quite familiar with this information. So if it's okay with you, we would certainly ask our dietitians and see if they could possibly present that information or get the information to the council.
Yes, if they could just perhaps email it to board members, that'd be great. Thanks.
Thank you.
Anything further? Okay, thank you, Allison and Marco, for your presentation. Motion moved by Member Van Passen and seconded by Member Martin that staff report HSS 20-04 be received as information, and that the Board of Health continue to remain receptive to ongoing updates on the social determinants of health. All those in favor? That's carried. And next presentation is on vector-borne disease program, and if staff could present.
So through the chair, Costa Lysenko, one of the PHIs, will be presenting the report.
Hello there. My name is Costa Lysenko. I'm a health inspector with the Haldimand Norfolk Health Unit, and I'll be presenting on our vector-borne disease program to council. So if I may begin, just an introduction. I am the co-chair of the vector-borne disease team, primary contact for healthcare workers seeking information on Lyme disease and tick exposures, and also I'm out in the field doing tick dragging. So in this report, we'll discuss the health unit's vector-borne disease program that's in place to monitor local tick and mosquito populations for diseases such as Lyme disease, West Nile virus, and Eastern equine encephalitis. This report will highlight the vector-borne disease program activities in the previous year and an overview of the plans for the current year of 2020. And in order to prioritize and plan activities for the program, the health unit traps and tests mosquitoes and ticks in the county, reviews official reports and statistics from other public health agencies, and interviews those affected with reportable diseases. So the first disease I'll talk about is Lyme disease, which is a large component of the program. Lyme disease, as a background, is an infectious disease caused by the Borrelia bacterium that is transmitted to humans by the bites of infected deer ticks. And in 2019, there were no new risk areas identified within the health unit for Lyme disease. 3 locations in the 2 counties were dragged in 2019. There were ticks found in all 3 locations in the spring, but none in the same locations in the fall. Provincially, there was 1,025 confirmed cases of human Lyme disease in Ontario, and this number almost doubled from 2018 when there was 612 cases. In Haldeman, Norfolk, there was 11 human cases of Lyme disease in 2019 compared to three human cases the previous year. So in terms of our public awareness activities, the Haldeman Norfolk Health Unit started a promotional campaign focused on schools. The aim was to raise awareness and build supportive environments to prevent, mitigate, and respond to children and school staff being exposed to tick bites. And educational resources were provided for students with varying levels of information based on their grade. And also there was a presentation done to the school board just informing them on the same issues. And then in addition to that, a number of public health education and awareness activities for Lyme disease were performed from May to December 2019. And this information was provided through radio, social media, newspapers, our website, and also smart TV ads around the county. The plan for 2020, as most of Norfolk County has been identified as a risk area for Lyme disease, and tick dragging activities will not be conducted this year just due to the COVID outbreak. Originally, it was planned that 3 sites were to be dragged for ticks in 2020, mostly focused around Haldeman County, just areas that haven't been identified as risk areas. In addition to that, the health unit will continue to develop promotional campaigns and raise awareness around Lyme disease and build supportive environments to prevent and mitigate tick exposures via social network messaging and other methods. We're also working with our partners to replace worn tick signage where necessary, specifically in the provincial parks. And then tick promotional materials and presentations provided to the Grand Erie District School Board are proposed to be also extended to other school boards, including the Catholic School Board. And finally, the health unit will distribute tick kits containing tick removal tools and tick identification information to local provincial parks then can distribute them to their patrons. So that covers Lyme disease. I'll speak to West Nile virus next. And as a background, West Nile fever is an infection caused by West Nile virus, which is typically spread by mosquitoes that become infected after feeding on birds carrying the virus. 80% of infections, people have no symptoms. 20% of people develop fever, headache, vomiting, or a rash. And then less than 1% of people, there is an inflammation of the brain spinal cord that can occur. In 2019, there were 8 mosquito trap locations in Haldeman, Norfolk, 4 in each county, Haldeman and Norfolk. These were set up bi-weekly between June and September. And in 2019, there was no positive West Nile virus mosquito pools identified in either county. In the province as well as in Haldeman, Norfolk, there was a lower West Nile virus activity in 2019 compared to 2018, and this has been attributed just to a cooler summer. In 2019, there was 1 human case of West Nile virus identified compared to 6 human cases in the previous year. And in total for the province, there was 21 human cases of West Nile virus. In terms of public awareness activities, so public education activities were performed from May to December, and this included radio, print, and smart TV ads. And furthermore, there was also communication about West Nile virus via social media and our website. For the plan for 2020 for the vector-borne disease program is to continue trapping mosquitoes in Haldeman, Norfolk at 8 different sites. These mosquitoes are trapped and submitted for laboratory analysis to maintain our mosquito surveillance program. And in 2020, the health unit will focus on surveillance, case management, promotion, and responding to standing water issues as priorities for West Nile virus. Next, I'll talk about Eastern equine encephalitis, also known as sleeping sickness. So this is a disease that's spread to humans and horses by mosquitoes. And this disease can result in a systemic or neurological illnesses, but some may not have any signs or symptoms at all. The mosquitoes that we trap within the counties are also tested for Eastern equine encephalitis. And the mosquito trapping efforts did not identify any mosquitoes that were infected with Eastern equine encephalitis. And there was no human cases in Haldeman, Norfolk in 2019. Provincially, there were 7 cases that were identified, which was also lower than the previous year in 2018. And just as with Lyme disease and West Nile virus, public education activities were conducted for Eastern equine encephalitis via radio, social media, newspapers, our website, and smart TV ads. In 2020, we'll continue just the trapping of mosquitoes and laboratory analysis to maintain the mosquito surveillance program. And lastly, I just wanted to talk about emerging diseases. So there's a number of emerging mosquito-borne diseases that the health unit continues to monitor. Some of the most important being Zika virus, dengue fever, and chikungunya. Across Canada as well, there's been a rise in tick-related infections beyond Lyme disease. Other tick-borne diseases that can impact human health include anaplasmosis, babiosis, and Powassan virus. And our vector-borne disease program will continue to monitor for new cases of these diseases. And our primary focus will be around messaging around the use of personal protective equipment, landscaping precautions, and as well awareness remain the main methods to help protect the public as of the diseases that are spread by ticks and mosquitoes. So that's the end of my presentation. I welcome any questions that you may have, and thank you.
Thank you. Any questions from board members? Board Member Martin?
Thank you, Chair Chop. I have 2 questions for staff. The first is, I wondered how you go about selecting the locations for a tick drag.
Thank you, Councillor. I'll try to address that. So we identify risk areas within the county. So a risk area is defined as a location where ticks are found in the spring and the fall. Then there's a 20-kilometer perimeter around that location that gets identified as a risk area. So we just try to just take a look at the map of the county and try to encompass all the different areas to identify where ticks may be a hazard to the local population. So I mentioned that this year we were set to drag in 3 separate locations. So these were identified by finding locations that fell outside any known risk areas, such as, for example, Turkey Point or Long Point, or other areas that are risk areas.
So is that complaint driven from individuals who may be out walking and find a tick on them and then they're reporting it to the health unit?
And no, it's not complaint driven. It's just active surveillance where we went out over previous years to look for ticks in Haldimand, Norfolk. Certain areas have already been identified as risk areas, which is known that ticks are present there and it's a hazard to the population. And then we just try to find areas where they haven't been identified as a risk area to verify whether ticks are present or not.
Okay, thank you. My second question is, how does the health unit plan to respond to areas of concern where there may be still water and West Nile might be something that you'd want to investigate? What does that look like? Is that also complaint driven? And then what happens when you select a location that you're going to go investigate?
So that aspect of it, Councillor, is complaint driven. So we generally receive complaints from the public and they're investigated by a health inspector, just obtaining the information and then conducting a field visit just to advise persons to either drain the water or larvicide, but it's more so on a case-by-case basis once the complaints come in. I hope that answers your question.
Member Columbus.
Thank you, Madam Chair. Your report indicates with respect to West Nile virus that there was low incidence in 2019 due to the spring and summer's cooler conditions. And the fact that we've got extreme heat this summer, do you expect a greater incidence of West Nile virus pool to come into effect?
I think it'd be uncertain for me to say one way or another. The information that we receive is just reported to us from the ministry. Generally, the hotter seasons lead to just the trend is higher incidences, but the statistics for that are unavailable. That is the data has been suggestive of that, but I could not confirm it, unfortunately.
Member Taylor.
Thank you, Chair Chop, and through you to staff. Said in the report that other tick diseases like babesiosis, anaplasmosis, and powassan, I probably butchered those, but are on the rise as well. Are those primarily from deer ticks, or are we going to start to be worried about all types of ticks? Because I hear a lot of people, oh, that's not a deer tick, don't worry about it. So just curious on that.
That is a council that is becoming a concern where other ticks other than the deer ticks are carrying some of these diseases. So yeah, other ticks are affected by these diseases as well.
Thank you.
Anything further from members? Member Van Passen.
Thank you, Madam Chair. Might be a silly question, but I've never figured this out, that our horses get needles every year to keep the West Nile and the encephalitis away. The dogs get a pill either once every 3 months or once a month for the ticks. How come we don't have that for people? Like, why can't I get a needle in the spring and have no worries of ticks?
Councillor, just through the chair, there is no vaccine currently available for humans. In terms of the rationale, unfortunately, I'm not sure myself, just as a health inspector. More of a medical question from my end, but there is no vaccine for humans. You are correct that there is one for horses, though.
Member Clemes.
Yes, I was speaking to some deer hunters last fall, and they had mentioned that they actually were skinning a deer and it had as many as 40 ticks attached to it when they were skinning it. And do you ever communicate with the hunters to find out where the hot spots perhaps are?
Councillor, we haven't had any specific messaging for that particular population, which has been focused on the general public. In terms of the hotspots, as previously discussed with the other councillors, we do have a map of the risk areas within Haldimand, Norfolk. Most of Norfolk County has become a risk area where we know that ticks are present in the spring and the fall. So it's established that there's a life cycles of the life cycles of ticks in the area. But to answer your question, we haven't had any specific messaging towards hunters.
Thank you.
Further questions? Okay, thank you. Motion moved by Member Rabbit, seconded by Member Martin, that staff report HSS 20-07 Vector-Borne Disease Program Update be received as information, and that the Board of Health support the Haldimand Norfolk Health Unit's Vector-Borne Program activities, which include active surveillance and education regarding prevention strategies for vector-borne diseases. All those in favor? And that's carried. If it's okay with board members, I think actually I just received a note from staff, if we could actually proceed with that consent item at this time then. Marlene, did you wish to discuss that at all, or did you want me to just direct a question? Okay, Member Michelli? Did you want to ask?
So through you, Madam Chair, if staff could actually present the report and then obviously entertain any questions from the board, that would be appreciated.
Okay,
thank you.
Thanks.
If I may then, if I could introduce Kike Ogansare, and she'll be presenting the report, and Kike is the program manager for the school health team.
Good afternoon, Chair and members of the board. My name is Kike Ogansare, and I will be presenting the Oral Health Report, HSS 2008, which is an update of the Children's Oral Health Program for the 2018-2019 school year. I have with me our clinic lead, Daniel Smell, here also to present the report. The objective of the Oral Health Program is to improve oral health in children by screening eligible children and providing access to preventive and referral services for children and youth from low-income families. There are two components of the Oral Health Program: the oral health screening, as well as the Healthy Smiles Ontario program. The oral health screening program is conducted in schools and community clinics. It identifies children with urgent and non-urgent dental needs, and our oral health staff help facilitate referrals so that children can receive the care that they need. The 2018-2019 school year screening occurred in all 38 publicly funded elementary schools, as well as 2 private schools. The oral screening was offered to all children in junior kindergarten, senior kindergarten, and grade 2, as well as all children in grades 4 and 7 in schools that were identified as needing a higher screening intensity. The total number of students screened were 3,352. Of that number, 10%, which is 335 children were identified as having urgent needs, and 241 children were identified as having non-urgent needs. For the Healthy Smiles Ontario program, this is a basic dental program funded by the Ontario government, and it provides preventive and restorative services for children and youth 17 years and below from low-income families. Clients are enrolled in the HSO program based on financial eligibility, as well as through identification during the oral screening process. Students identified as requiring urgent dental treatment qualify for the Essential or Emergency Services stream, which we also call the EASE. And this is delivered by participating community dental offices. Students identified as having non-urgent tooth decay are able to access care through the HSO clinics at our health unit office locations in Simcoe, Dunville, and Langton. Our dental staff also attend the health center night, one evening a month, to provide oral health screening, topical varnish applications, and facilitate enrollment in the Healthy Smiles Ontario program to children within the Mennonite population. We were able to screen in 2018-2019 school year, we were able to screen 1,020 children in our HSO preventive clinics. 465 children were new enrollments. 421 children were identified as having urgent needs and went through the EASE program, and 491 children received treatment in our HSO clinics, in our health unit office clinics. Our health unit also offers targeted intervention programs to schools that screen at a high intensity level. 1 or 2 schools per year are offered these programs. We would have loved to offer more, but due to limited resources, we're only able to offer 1 or 2 schools per year. One of such programs is the Tooth Brushing Initiative, where students get to brush their teeth as part of their daily school routine. Another program is the Fluoride Program, where students receive fluoride varnish applications in school twice a year. In this school year, in the 2018-2019 school year, 359 students we were able to reach 359 students in the Toothbrushing Initiative, and 530 students were seen through the Fluoride Varnish program. In conclusion, there has been an appreciable improvement in the oral health of children and youth in the Haldimand and Norfolk counties. Statistically, we have seen a steady decline in urgent and non-urgent cases over the last 5 years, from 32% in the 2014-2015 school year to 16.8% in 2018-2019. The Haldimand and Norfolk Health Unit Oral Health Program continues to work towards program outcomes that will help to improve the oral health of children and youth, and as well as to improve access to care for children from low-income families. Thank you, and Danielle and I will be happy to answer any questions that you may have.
Thank you for your presentation. Any questions from board members? Member Michelli.
Thank you, Madam Chair. Ladies, You indicated that there is a higher rate of tooth decay among the Mennonite population of children living in the southwest part of Norfolk County, and that staff attend the help center nights one evening per month. Are you able to give us some idea of how well that is attended by the Mennonite community, and perhaps maybe some numbers on the number of children that have been helped with that part of the program?
Yeah. So initially we found that it wasn't attended well in the summer months, so we skipped the summer months, and usually there's 40 to 80 kids. It varies quite a bit. Quite often there'll be 80 kids, and then word gets around that people had to wait, and the next time it's 40. So usually it's between 40 and 80 kids, which is a ton of kids to screen in a night, and it's a very, very useful night.
Thank you, Madam Chair. Thank you, ladies, for that. That's very encouraging. I sometimes always wonder if we are making any inroads with that particular demographic, and it sounds like we are. So thank you very much. Good job.
Member Columbus.
Yes, I just wanted to address that, the Mennonite situation too. I just wonder if in today's modern world and all the issues with stigmatizing certain groups, that we should perhaps not be singling out a certain ethnic culture, and maybe we should just have a broader version of, say, the geographic area versus the actual fact that we're stigmatizing in ethnic culture.
Yeah, the screening process with schools has health equity built into it so that people that need the program access it. And we've just found that naturally has brought a lot of low Germans to getting help. The program, and then from there, we universally say, whoever's high risk, we give them more things. So it's just happened that the health equity built into the program has helped us help that community.
Okay, further questions? Thank you for your presentation. I have a motion moved by Member Michelli, seconded by Member Martin, that consent item A be approved and the following resolution adopted. That staff report HSS 20-08 children's oral health information be received as information. All those in favor? Carried. And moving on to the next staff report is the Community Needs Assessment Report, HSS 20-03.
So, thank you, Madam Chair. Kate Bishop-Williams, our program evaluator, will present this last report.
Good afternoon, everyone. Through the chair to the committee members, I am Dr. Kate Bishop-Williams. I am the Community Needs Assessment Program Lead and an epidemiologist by training. So through you, I would like to present a report as information only at this time. However, I'd like to address that this is the first community needs assessment that's been conducted in several years, which means that I anticipate that there might be several questions, and I'd encourage you to ask for clarification when I come to the finish of this presentation, if there's anything that I can clarify for you at that time. So to set the purpose for the community needs assessment, it really was driven to understand the community needs and to set the priorities for action for both health and social services for Norfolk County and across our public health region for Haldimand and Norfolk together. And the idea is really to seek local input as a way to address what the community needs and how we can meet those needs through program initiatives. The research component of this project involves 4 key components. Those components are a community profile, a survey, focus groups, and interviews. The first component then was the profile, which conducts a scan of the available information in the communities across a broad range of resources as a way to get a sense of the context in our local community. Of course, as local representatives and those sorts of things, it's important that we recognize what available information already exists and how we can build on that information to greater understand what's happening in our communities. And the second component then is a survey that was conducted of our community members. And it was available in online and paper formats. So the online format was through a web-based platform for surveys, as well as paper copies of the survey that were available at numerous locations across communities throughout Haldimand and Norfolk. And this survey aimed to understand the perspectives and behaviors for both health and social services actions and individual behaviors of our community members. We had excellent response rates from the communities at large, with 427 survey responses through this program. The third component was really two pieces. So the focus groups and interviews really were treated as a single data set, but involved an opportunity to hear from our community in both individual settings, as well as to hear from our communities in groups if that made them more comfortable. And so we sort of had opportunities for community members and key informants to participate in either focus groups or interviews, sort of at their preference. We had 46 participants in focus groups and another 124 interview responses. And those individuals represented a variety of different lived experiences across our different communities, as well as a number of partner organizations across the two communities as well. And so in collecting all of these lived experiences and all of these perspectives, it really allowed us to collect a deeper, sort of more rich experience of the community members that we were interviewing by allowing us to ask those follow-up questions that really dig deep into what their experience is living here. After all of these different data sources were collected, they were analyzed independently and then as well in a process called triangulation, which allowed us to look at what information we were collecting from those different sources and how we could bring that information together to get, again, this fullest and robust understanding of what was happening in our communities. And so that triangulation process allowed us to look for where we might be seeing similarities and differences in different populations. So I'm going to highlight a couple of key findings for you now. The first and probably most prominent finding was mental health and addiction supports. This came out as a top priority for many community members through the survey and through the in-person focus groups and interview conversations. The participants acknowledged that there's a high need for mental health and addiction services in our community, but that they're all often difficult to access. Some of those difficulties that they identified were things like wait times for accessing programs, the cost of programs that had shorter wait times if they were looking to sort of buy their way into some of those programs, that cost was often prohibitive for those who needed the services, as well as issues around transportation and acknowledging that they were having difficulty getting from the community that they might live in to the community where those services are available, particularly if they didn't live in Simcoe but lived in one of our more rural communities across the county. The second major health need that was identified was physical health needs. And as a public health unit, that's something that is obviously very important to us. The key areas of physical health that came up again and again in conversations and through the survey were areas of interest in nutrition, so access to healthy food, those sorts of things, access to information about and rates around cancer diagnoses in the communities, and sexual health services, particularly things like sexually transmitted infections and diseases. The other major component of physical health that came up in conversation quite frequently was an acknowledgement of a difficulty in finding available family physicians, or what appeared to be a difficult thing to attract physicians to our region, or to have specialists for various types of services such as cardiology. And so that was something that many community members highlighted for us. The third major priority area was poverty. And one of the things that was evident in the conversations and in the survey data was that poverty was something that was really sort of cross-cutting across all of the themes that we identified as major themes in this data. It intersected with all of the different concerns that they had and really highlighted the psychological and physical stresses that poverty was putting on individuals living in our communities. The last two major areas were access to products and services and organizational structures. Under access to products and services, things that came out most commonly were things like transportation, particularly around being able to get to work, which would have helped to address some of the concerns around poverty, as well as childcare, which also was commonly linked to being able to get to work and those sorts of things, with concerns around limited availability of childcare spaces. Some of the other things that were addressed under access to products and services were food, and identifying some of those food deserts where it was difficult to access things like a grocery store in some communities. And lastly, youth programming. And one concern that came up again and again, if ever there was a conversation about youth, was availability of services and activities and those sorts of resources that youth might be most in need of. And so that was something that came up quite frequently in conversations, not only around youth, but also around mental health and addictions, suggesting that the youth mental health and addictions problem or issues that may be presenting themselves in the community might be best addressed through increasing the availability of youth programming and services. And lastly, as I said, the final major theme that came out of our findings was organizational structures. These organizational structures included collaboration, where the community was often calling for increased collaboration between the Health and Social Services unit with existing partners across the communities. To be clear, this was also identified frequently as a strength of the programming that's being conducted at Health and Social Services, but many community members and community partners acknowledged that continuing to strengthen those existing relationships and build new relationships with other organizations would allow us to really deeply build on some of those things that we could be working on in the communities, acknowledging that Health and Social Services as a single entity certainly couldn't address every need that the community would potentially bring forward, and that building on these partnerships might address ways to build some of these successes into our programming in the future. In addition to communication between organizations or collaboration with other organizations, we also heard calls for increased communication and transparency with the community, again acknowledging that this conversation did sometimes identify it as a success, where people were saying that they loved hearing from the health unit, identifying some of the ways that they like hearing from the community, from the health unit out to the community, such as through social media, but acknowledging that they would love to see an increase in that as well. And lastly were things like operational changes and anti-oppressive actions. And under that heading would include things like making spaces that were as open and accepting of the community as possible when walking into our buildings, and really trying to work on things like increasing the availability of hours so that people who were working the same hours as the health unit staff would then maybe be able to access health unit services in the evenings or on weekends. So there's a lot of information contained in this report, and what we would like to do is really be able to take the information contained in our findings and in the report that's been presented, and we would like to be able to put it forward as information to all of you today, as well as to be able to use it in strategic planning in our coming phases, whether that's later in 2020, pardon me, or coming up in 2021. These are really important findings that we believe can set the basis for what our strategic planning can look like in the next phase. So with that, we request that this report be received as information and used as an opportunity to endorse the strategic planning steps that follow this. That's the end of this presentation, and I would be most happy to answer any questions that you may have at this time. Thank you.
Thanks, Dr. Williams. Any questions from committee members? Or Board of Health members, rather, I should say. Member Huffman.
Thank you, Chair Chop. It's a great assessment summary, and it obviously lends itself really well to the social determinants of health. I just wanted to, a couple things that really stood out to me was obviously this is going to be a template going forward for what we can look for in Haldimand and Norfolk through the Health and Social Services. Are there any ideas at this point in time in terms of ideas to expand the supports for mental health, as in particular for youth? And actually, I'll go with that one, and then I have a couple other ones. So just wondering if there's any plans in place, or if you have any ideas how you can expand on those services.
Through you, Chair, to Councillor Huffman and to the other councillors at the table. Thank you first and foremost for your words on the report. I think that it's great to acknowledge the link that we're making to social determinants of health through this report, and that's really a critical component of moving forward with this. As far as a template for actions, I think that that's where the strategic planning really comes into place. So what this does is provides us with this great base of information that we can then use to develop the strategic plan. But with regards to, for example, mental health and addiction services and youth priorities, each of the areas of the report that are highlighted through our conversation now, as well as in the report that you've received, one of the exciting things about seeking out all of this community information is that we also get really exciting, innovative ideas from the community about how we can begin to address some of those things. And so there are several recommendations included in the longer version of the report that's provided to you that are directly collected out of the voices that we heard in the communities, as well as sort of substituted or enhanced with information from the literature about ways that we could expand forward. I think it would be too early for me to say what the appropriate next step would be, but I think that the information provided from the community members is the best place to start as we head into our strategic plan. And I think that it's exciting that you're addressing some of those ideas at this time so that we can continue to move forward with those conversations.
Okay, sorry, thank you. So, I mean, obviously, it's a really good thing in terms of working with the collateral agencies, and they're going to have some ideas as well. Now, the other thing I just wanted to comment on was the meet the people where they are, and I think that's a great determinant in terms of getting the information from the people who actually require the services. The other thing that really stood out to me, and I just wanted to ask, was are there plans for any training in terms of the providing trauma, any plans for training in terms of providing trauma-informed care for the staff? Is that something that's going to be looked at going forward?
So I think it would not be my place to comment on what next steps are for training that comes out of this report. But what I will say is that it's abundantly clear from the management here that it's always important to continue to be training our staff here at Health and Social Services. So to say what comes next or when that training might happen wouldn't be my place. But I would say that there's certainly an acknowledgement that it's always important for us to be training and building our capacity as staff here. And that I think that this report highlights that our management is aware of that and how important it would be for this to be something that we're thinking about in the next rounds of training for our staff.
Okay, thank you very much.
Shankar, go ahead.
So, members of the Board of Health, Madam Chair, I think it's a really important thing that we have to advocate for enhanced mental health services, both in the physician and non-physician services and residential and non-residential programming. When I started about a year ago, I met with the chief of psychiatry in that advocacy role. I think that if there's one thing that we can do to improve the health of the population is to invest more in children and young people, especially in the domain of mental health. And I hope that in September that I'll have a chance to speak to that again. There is and I could talk about this topic forever, but there is a clear overlap between people who have challenges with addictions and people who have problems with mental health. And that can be a lifelong challenge. So spending a bit more resources on that early in the course of illness or early in the course of life, I think is a very worthwhile investment. So thank you for that opportunity.
Thank you, Shankar. Any further questions from board members? Okay, in that case, I have a motion moved by Member Guys and seconded by Member Michelli that the Community Needs Assessment Report be received as information and that the Board of Health endorse the use of the findings to develop a new strategic plan for the Haltom Norfolk Health Unit and continue to build and maintain strong relationships with community stakeholders. All those in favor? Thank you, Dr. Williams, for your presentation. Okay, so I think if it's okay with the board, I think it's better that we maybe push through here with the Board of Health meeting while we have both Shankar and Marlene present. So in that case, I guess the next presentation would be from Mr. Burgess in regards to the response to the Agricultural Advisory Board. Yep.
Thank you. Through the okay. Thank you. Through the chair to the board. I do apologize for this being rushed to the board, but we are trying to act as quickly as possible. This presentation was a request, is derived from a request from the board. The board had asked me to discuss with the AAB, the Agriculture Advisory Board, what their official position is with regards to how to deal with farming in the world of COVID-19 and what would be their recommendations for both the 14-day initial travel quarantine period and the post-quarantine period. I would caution the board that this presentation is not intended to be exhaustive of all the comments. It's intended to be a high-level presentation to the board for information. And I would also suggest that we are working to obtain dates that we will be meeting with the AAB, hopefully this week, to discuss in more detail their recommendations and some of our comments. So if I can get the next slide. So the AAB's position was essentially, we asked for both the self-isolation period after their arrival to Canada and the post-isolation period for the remainder of their stay. What I've done is in Appendix A of this presentation, you'll see their complete position. You'll see their background material that they drew from. And what I'm providing in the next slide is just, next couple of slides is just a summary of their position. So the first item was the initial 14-day travel self-isolation period. Here the AAB's position is to undertake the initial quarantine period in the bunkhouses with spacing to accommodate 2 meters of social distancing. They also wanted to translate this into a percentage of normal occupancy capacity, so the 70%. My reading of the document is that this would allow for ease of administrative responsibility on the Board of Health. So similar to the 3 to a bunkhouse, that's very easy to administer. The 70% would in their minds be easy for us to administer. There was some other recommendations that the AAB had put in there, including having a worker coordinate health checks and reporting that to the farmer. We will have some questions of AAB to exactly how they would handle this. You'd see the note there. Generally, when you're in a 14-day isolation period, you cannot add people to that isolation period during that isolation period because then the clock restarts. And the way workers can come into the country, it may be difficult to organize that because if you put 20 people in a bunkhouse that could hold 30 and 10 come up later, are they restarting the clock and extending that 14-day period? The next slide is the post-travel isolation period. So this is after they clear their 14 days, what's the position of the AAB on that? Their position is that they would attempt to maintain the 2-meter separation when possible. However, the intent would to move up to full occupancy limits of the bunkhouses. They would also propose utilizing work or group cohorts as part of their plan. And their position was also to allow for positive asymptomatic individuals to continue to work. Staff's response to the AAB's position is Though there's certain parts of their position that we would be supportive of, overall, the health unit's not supportive of the plan. They view that this increases the risks, and the plan is similar to Windsor-Essex's original approach to the situation. The other thing that I've challenged all parties on here is to do the four-way test. A multi-view approach is a good way to check when you're looking at public policies. And if you see in the box to the right there, the four questions or the four-way check on this is, what's the impact to the worker? What's the impact to the farmer? What's the impact to the broader community? And what's the impact to the Board of Health or the counties that are supporting that? So when I look at those impacts to each of those stakeholders on the next slide, thank you, you see that I look at what are the stakeholder interests. So for the farmer, obviously they need economic viability of any program that they're working with. They also want to obviously be a good employer and be a good community member. Worker interest, the workers there, they would be focused on their health and their economic interest. Community interest, the community obviously doesn't want community spread. If there's an issue in the farm, they don't certainly want it into the community, and obviously cost to the taxpayer. And the public health interest, also is reducing community spread and being able to manage the risks and the resources. So when we go through this list, we don't see the AAB's position working for the worker or the community and potentially the public health interest. So in a bit more detail on the next slide, I've broken down the four-way test for both periods, both the travel self-isolation period and the post period. So the biggest issue is when you're self-isolating or doing that 14-day self-isolating period, the more people you add into it is the greater risk to the worker. You could be essentially asking healthy people to self-isolate with sick people. If you put 40 of them into a bunkhouse, the chances that you're asking someone to self-isolate with someone who has the illness increases. And if a worker who was healthy gets put in that situation, gets COVID-19, and then has to have weeks off, his risk is increased for either economic loss or health loss. And the other big item that we would highlight is when you have an outbreak, when you have 3 people in a bunkhouse, it's very easy to manage. But if you have 40 in that, it becomes a bigger risk, obviously, to the county, because their public health team then has to deal with that. The next slide is the post-travel, the self-isolation period. And essentially moving up to the maximum capacity in a bunkhouse has risks. But under both the current approach by the Board of Health or by the health unit and the farmer position is not that much different. So there are risks with both approach. I would outline the very last line there is that with just the one outbreak that we had, you have to remember the broader implications to everyone. And just with our one outbreak, we had a number of hospitalizations. We had 7 admissions to ICU. We had 2 individuals, because of their medical complications, ended up transferring to London Hospital. And we obviously had 1 death in our community. So, I know the newspaper picked up our $250,000 worth of cost to our health unit. There's significant cost. Anytime a person is staying in an ICU, the cost per day to manage that, it might not be on the county's dime, but it's certainly on taxpayers' dime when they're doing that, and those costs can be significant. And obviously, no one wants to factor in, the death of an individual. So I just want to highlight that. The next slide shows, frankly, what's pushing some of these issues, and I call it the backdrop, or the 2 constraint issues. At the end of the day, there's 2 major constraints that are causing this issue. The first one is the on-farm accommodation constraint. At the end of the day, there's only so many bunkhouses or so many beds in Norfolk County for migrant workers. And you need to be able to find appropriate accommodations for the workers. And every time you put in a plan that reduces that level of accommodation, it requires a displacement. And you know, how can you manage that displacement? So that's a key constraint. The second constraint is of particular interest to the Board of Health. It's the public health capacity constraint. At the end of the day, we only have so much resources from a public health point of view, and frankly, from a broader medical health point of view. If you looked at the resources that was required to deal with one outbreak here, you know, the reliance on the Delhi medical team, the reliance on our EMS staff, the reliance on our public health staff, and then frankly, the reliance on not only our hospital staff, but now hospital staff in London, and frankly, we had reliance on public health staff from another public health unit. So if you looked at just that one outbreak, it really pushed our constraints past to where we would normally be able to accommodate. So if you end up with 2 outbreaks, you know, we don't have that ability, that resource capacity. So those are the 2 big constraints that are causing, you know, this issue to really bubble up to the forefront. The next couple of slides I'll say is important, and it really focuses on the accommodation issue. And there's a wide range of options for accommodations, from, you know, the very best, where every person would have their own bathroom, their own sleeping quarters, their own kitchen. That would be best in class, all the way to where you have a congregate setting, which has the highest amount of risk. So the chart on the next slide, I'll spend a little bit of time on, because I think in one page this really illustrates the issues and the positions very well. So when you look at the far left, where you would be in best in class, if you wanted to reduce your risk and reduce constraint on the public health unit, everyone who would travel to Canada would individually quarantine, one to a room. That really reduces any type of risk for an outbreak. If someone becomes sick, you're dealing with one individual. And on the post-quarantine or the post-travel period, you would have the same living arrangement. They would live on their own. That way, spread is limited. So you get 2 risk factors of low for both of those. That's why it's on the green part of the arrow. The problem with that, frankly, is the accommodation constraint. It's frankly not possible to do that. We cannot give every migrant worker an individual unit like that. It just won't happen, especially not in a short order. And the cost obviously is quite high. So as you can see, there's variations of each of these. You can do the quarantine period with 1 to a room, and then, you know, work on the farm in very small pods of individuals living together. If you move over to the fair, where you quarantine for that original travel period to a small isolation size unit, so the 3-person rule, that still keeps you at a low risk. And then if you move into a situation where you're in congregate living but with 6 feet of separation, you know, that would move you up to medium risk. Even that scenario, we're not sure is possible, quite frankly. The health unit has taken a number of bunkhouses, and they have measured them out for 6 feet. These are live, real farmer situations where the health unit inspectors help the farmer measure out 6 feet of social distancing, and to ensure that all those rules would be in place. You know, and the capacity of that bunkhouse was reduced to close to 50%. So if you took out 50% of capacity from all the bunkhouses, you really can't do that over the long period of time, especially over the next few months, because there just wouldn't be enough places to house the workers. So that leads us to the next column, which is the risk-adjusted column. And this is our current position, where you have the 3-person rule, so you have the small cap on the initial travel isolation period, so that gives you a low risk at that point in time for the travel risk. And then you move into the congregate living setting. So that means that bunkhouses can be fully utilized for the entire growing year. That admittedly comes with a high risk. but it allows for the accommodation of the workers to happen. So you don't need to build new bunkhouses, you don't need additional stuff. The only requirement for accommodation, for additional accommodation, is for that 2-week period of initial quarantine, not for the entire growing season. If you look at Brant County, their rule was you had to, both for the 2-week quarantine period and for the entire growing season, you had to have that congregate setting with 6 feet of separation. And so no bunk beds, you can't have bunk bed usage. It really reduces their total capacity at that point in time. We're not sure that's possible, to be quite frank, to execute that here in Norfolk County with the amount of workers we have and the bunkhouses. It might be, but I think it would be very difficult to actually execute that model. And then you move over to the high-risk position, which is for the travel quarantine period, you would congregate with six feet of separation, and then you'd move into congregate living with maximum bunkhouse capacity, so what you are doing today. We're not sure if it's fully possible to do that at this point in time, but we are saying it's possible. And obviously that's, from a farming point of view, that is likely the lowest cost situation that you can have. But that is more similar to the Windsor-Essex model, and the Windsor-Essex model has had difficulties that we've seen. So when you look at it, best in class and very good approaches are great in theory, but there's recognition that those are not possible. And now we're dealing with 3 scenarios that have different degrees of possibility, frankly, of being able to execute, and all come with elevated risk levels, both to the community and to the worker and to the farmer. So, that slide, feel free to review it and have some questions on it, but, it's done to try to put this on one simple page that people can kind of take a look at. And we can argue about the gradients and whether something's a low or a low medium or a high. The intention is to show directionally where the risks are going and to show where the constraints are. The next slide I find is interesting, is comparing the 2 positions, comparing the public health position here to the AAB's position. When you look at the post-travel period, it's the same. The health unit is willing to accept the high-risk situation with living in a congregate setting, because we understand that from a bed capacity point of view, we have to deal with that, and we're willing to live with that high-risk situation. The difference really only comes down to that 2-week period, that travel self-isolation period. The health unit's point of view is when you create small isolation groups and you put a significant amount of focus on that 2-week period, and to use Shanker's term, you burn out the virus. You make sure that everyone who's leaving that quarantine period is clean and have, they're not going to transmit disease, they're at 0%, then you move them to the farm and you have no risk at that point in time. Did we have a failure in Norfolk County? Yes. Was it because the execution of that travel quarantine period wasn't done? Well, that's up for debate. But if you can clear everyone through so that when they're moving to the farm, there is no risk at that point in time, then you are in a congregate setting where everybody is well at that point in time. If they fail during it and they suppress their illness and they don't tell anybody and then they move to the farm with COVID-19, it will spread through the bunkhouse very rapidly, and then you have a major outbreak. So if you focus on that 2-week period and clean them up, the public health unit is willing to accept that risk because it's a risk that works with all the other constraints there. The concern with the AAB's position is when you start going up to 70% capacity, you could have larger travel outbreaks during that period of time, and it's much harder to focus your energies to make sure that people are leaving that 14-day quarantine period, and that 14-day quarantine period was executed correctly to reduce that risk. But the risks for the majority of the growing season is the same. So really the only difference between the two positions relates to a 2-week period in the whole growing season. So some key questions, that I think people need to ask are, and I specifically put this to the Board of Health, is how much additional risk, should a Board of Health suggest to take on? We're already at the one end of the scale, and we're 2 notches away, frankly, from the way I look at it. So how much additional risk do you want to take on? Is now the right time to take on that risk? And then from a public policy point of view, I think you need to rationalize, the risk tolerance for migrant workers with other parts of our society. So, if the position is, there's no difference in the world between what happened pre-March 12th, whenever the state of emergency was declared, and post-March 12th, in other parts of the society, I'm not sure you'd accept that. I don't think anyone's going to accept, come September, that it's okay if there was 30 kids in a classroom before, 30 kids go to the classroom again. We have debates here about beach use. We can't even skate with a full set of kids on an ice. Before you might have had 30 kids on the ice, now you're limited to 9 kids plus a coach. So when you look at how we're adjusting everything else for this, and frankly for uses where there's a lot less risk, the risk of transference for a 1-hour hockey practice versus living, cooking, using shared washroom facilities is a whole bunch different risk profile. But we're making significant adjustments in other areas of everyday life. So the question becomes, how much risk are you willing to accept, and how much adjustment do you think is required for migrant workers in this situation with essentially a high-risk situation? So those are 3 questions that that we thought should be asked, and you need to be able to answer those questions, I think, before you move forward. It's certainly questions that the health unit and staff ask all the time when we look at these issues. So on the next slide, from an overview point of view, from the proposition from the AAB, there are a number of positive things that staff agree with. So I don't want to be completely negative on this fact. Farmers are talking about more active health screening. They're talking about increased separation and increasing physical barriers, and they're talking about creating cohorts. Those are all things that the public health unit agrees with and is working with farmers on. The issue really comes down to the difference. Like I say, it really comes down to that 2-week travel quarantine period. From a final conclusion point of view, though the farmers' proposition has a number of positives that should be capitalized on, and we'll certainly work with them, we just don't think moving closer to the Windsor-Essex model at this time is the original Windsor-Essex model at this time is appropriate. We don't think taking on additional risks is appropriate at this point in time, especially for when we're dealing with essentially a 2-week challenge. Now, I wanted to map out a way forward and solutions moving forward, because I hate a presentation that doesn't provide a solution. And when I look at the solutions, I think there's a number of considerations that we have to look at. There's still a significant number of workers that are to come into this county this year. The issue's not done. I've certainly heard of, and I understand, and I'm empathetic and sympathetic towards the strain on farmers. The Councillor Columbus and the Councillor Van Passen have certainly made it known vocally about the strain farmers are under, and I don't underestimate that. And I think there is a solution for that. The other considerations, we do have key constraints with regards to accommodation resources and healthcare resources, so we have to be cognizant of those restraints. And also, frankly, communities have been held back. We are looking to move to phase 3. there's lots of mixed feelings about whether there's going to be a second wave. And, we need to factor those into, into these solutions. So, staff still maintains that the hotel solution, especially if it's funded by all levels of government, is the best way forward. And the reason for this is when you look at the four-way test on this solution, is workers are safely isolated without additional risk for them. It works for the worker at the end of the day. It puts them in the safest position. If there is additional government support, there is a lack of undue financial pressure on the farmer, and that reduces, and the hotel solution actually reduces their risk also. Because if they put 40 into a bunkhouse and there's an outbreak and they lose those 40 workers, that is risk to the farmer. We can all talk to the one farmer who's had an outbreak. There was significant risk to him when he had to deal with that outbreak. The health unit would be able to better manage this risk under this program. The community risk is reduced, so it's good for the health unit or the county, it's good for the community. And this approach does not constrain the existing accommodation supply that's been working. It doesn't reduce the accommodation supply because we can house those workers for that 2-week period and put them to the bunkhouses, and then all the farmers can maximize their bunkhouses. And frankly, it's been working in other provinces. It's a model that has worked. So when I look at the near-term solution, I just put these numbers out. This is just an example. But if we assume the cost is $1,800 per worker to do this, plus, frankly, their wages for that isolation period, the federal government has already put $1,500 on the table. You can argue whether that should be for the isolation cost or that should be for the wages. Different people look at that $1,500 differently. The county has already offered to take up the administration and monitoring. So our resources to administer and monitor that program, we would put our financial and our people resources behind that. So it takes a strain off of the farmers. They don't have to arrange that stuff. They don't have to administer it. We would administer the programming for it. And if the province matched the federal funding, the farmers would then contribute $300 per worker for the 2-week period. So the feds put in their $1,500, the province puts in their $1,500, the farmers put in their $300, and we put in our staff resources and administrative capabilities to execute this program. We think this recognizes the fact that we can put people off-site in hotels during the travel quarantine period. It's much easier to do that. We can monitor it, and it's a 2-week issue we got to deal with. And then they can come, we have then confidence, and the community can have confidence that when they're back on the farm, that they have cleared through all the protocols, and that the community risk now is limited. At the end of the day, if they clear travel quarantine, the level of assumed risk that they have is the same as anybody else in the community. And does this cost a bit of money? Yes, it does. But on the flip side, I'm being conservative, but a large outbreak can break $1 million pretty easily. I don't know what the current daily cost is for a person in ICU, but you start putting people in ICU for 30, 60, 90 days, it starts to rack up there. We racked up $250,000 pretty quickly on an outbreak. The farmer racked up significant cost by housing 170 workers for 2 weeks and paying them for 2 weeks. The numbers on one outbreak, it would only take a few outbreaks to eclipse the cost that we're talking about here. So we still think that is the best solution for everybody involved, for all the stakeholders involved, if we can sort out the monetary issue. What I'll end with is on a longer term solution, this is not going to come as a surprise to anybody. There needs to be a change in how migrant workers are accommodated. That's not going to happen overnight. That's not going to solve the problem today. What I would point to is I can circulate an article to the Board of Health members, but there was a news article in the Windsor Star. There's a new approach to migrant housing, migrant worker housing. There's a farmer, he started this 2 years ago. It's under construction right now. It was started before COVID-19, but he's got 2 workers sharing a bedroom and a bathroom, and 3 of those pods sharing a kitchen. All the workers have direct access to the outside. Those types of housing units would certainly be very useful in this type of situation. And he's doing it for 600 workers outside of Windsor. It's something that we need to take a look at. But without, when we're not at that point in time where these congregate living settings are still going to be around, we believe you need to manage these risks aggressively, because when you don't manage it aggressively, you get large outbreaks. And I think from a staff point of view, we look at a couple of things. We can't have a farm fail because of an outbreak, and that's a real risk. And that, frankly, is when you look at what the Minister of Agriculture for British Columbia said when they had a major farm outbreak and they switched their program to the hotel program. She said the cost of losing a farm was too much, and so that's why they switched to that program. So we don't think we can have a farm fail because of an outbreak. Frankly, we as staff, we can't accept the risk of a migrant worker dying. That is too big of a risk to accept. And we can't have the community lack any confidence in this program. Like, when you think about, we've seen it in other communities where if the larger, broader community has confidence issues with the riskiness of farm operations and the riskiness of foreign temporary workers, it leads to bad outcomes in the community. So we need a program that works for everybody, and we think that the solution, frankly, is to move to the hotel model, deal with the 2-week issue. That's the difference. It's 2 weeks. It will cost some money. It's not foolproof. There's still a higher risk solution. There's still risks that we're assuming. It's not a low risk model. But we think, based upon the constraints that are there and that are present, it's the best solution that we have going forward. Burn it out. Make sure that when they move to the farm, we are 100% confident that they're healthy. Put them on the farm. Let the farmer, work the whole season at maximum capacity in their bunkhouse. And you reduce the risk up front, and that reduces the risk on the tail end. And it's really a 2-week issue at that point in time, and there's some cost to it. So I was asked to get the AAB's position on it. They've provided their position. We've provided a response here to the board. We'll be providing this response to the AAB. Frankly, I'm sure we'll be having lots of discussions with the AAB as we work through this, and as we look to not just the 2020 farm year, but also, frankly, the 2021 and the 2022 farm year. But with that, I'd be more than happy to answer any questions on that, or if there's anything very technical, I have 2 much smarter people in the room to also respond to questions.
Questions from the members. Member Columbus.
Thank you, Madam Chair. Jason, was this document shared with the Agricultural Advisory Board, this overhead, and were they aware that it was being presented today?
Thank you. I gave, the document was finished yesterday. It was sent to the clerk at about 4:30. I notified the chair and the vice chair that we were responding, that our staff response was in order. And we're trying to arrange a meeting. You probably haven't seen the email, Councillor Columbus, but there were some emails to set up a date to discuss it this week. So you're CC'd on that email, but it was, it took us a little bit to respond to it. We received the AAB. I received it in my email on last Saturday. So it took us about a week to put a response together, review what they had, put a response together, and send it out. And what we wanted to do was make sure we were responding to everybody as quickly as possible. And we'll certainly have some discussions with the AAB on this going forward.
I know that they're all very, very busy at this time of year. And have you spoken with the federal government or the province with respect to this motel accommodation proposal? And what's the status of their thoughts on this?
Through the chair, this board had authorized a letter to be sent out to the federal government, the provincial government. I know there was a whole host of names on that because this was approved, that suggestion was approved by the board. Officially, we haven't heard anything back from them. I've been in contact with them to try to get a response back. I think this package, frankly, will also be sent because I think when you know, I think saying, hey, let's do what BC doesn't necessarily translate all the issues as well, and I think I'll be using this package to go back to them. I know both Shaker and Marlene, there are more federal and provincial agencies sitting in GAB today than any other point in time in history, probably. So there are lots of discussions going on, but nothing official has come back. But I will, you know, we will be pushing forward with it over the next week or so.
And I know that there's several farmers have purchased trailers to accommodate the isolation. Like they've spent thousands of dollars on these trailers. So what's that do to the motel? If you went to the motel accommodation, it kind of, they end up with a trailer that they're not going to be utilizing for the purpose they purchased it.
They would still be able to use the trailer, and they'd still be able to use the, you know, if they needed it. The concept of the hotel is to take that strain off of it. I think one of the challenges is for the second wave of workers that come in, they have existing workers in the bunkhouses currently. And now if you add travel quarantine workers into existing bunkhouses or into existing trailers, it complicates that management a bit more. But there would be no requirement for them to automatically enroll in the hotel program from our point of view. So they could still, if they had a quarantine plan that the medical officer of health approved of, they could approve for it. But what we think is on a majority scale, this is the best way to deal with it. It takes it out of the farmer's hands, and it, you know, and it puts the administrative burden onto us to execute on and reduces the risk. But if, you know, if they had 50 workers coming in and they wanted to deal with 6 of them, and it was a plan that the board or that the health unit approved, that wouldn't be an issue.
My last question, Madam Chair. With respect to the motel accommodation scenario, the outbreak on the one farm that was a major outbreak, were those workers not housed in a motel scenario?
Yeah, through the chair to the member, it was a combination. So each of the farmers used some hotels, excuse me, and some on-farm accommodation.
So I guess, is there a greater risk, or with that particular case, was there some risk with the motel use as to why there was an outbreak at that particular farm? Because they were housed in a motel scenario.
I'll start the question and I'll have my counterparts answer. I think what's been universally accepted by the province and by the health units is there's a suppression of information. Workers who should be disclosing symptoms are not disclosing symptoms. And if that's the case, then it doesn't matter what system you're going to use, you're going to run into problems. You know, we do have some concerns statistically here with the farmer checks. I can't remember the number of checks that happened, but there was 0 health issues raised under thousands of checks. You know, no one had a cold, no one got an allergy, no one got a sniffle. If you run it as a program in a hotel where you have public health officials monitoring it more closely, because again, it's a concentrated effort, we think that putting public health officials more directly in line of that quarantine will have better, more effective quarantine periods. Even the steps we took with this, where we did have inspections and farmers knew that they were going to be inspected and there was an expectation of that, we think compliance was increased. And that's why we think, frankly, that Hold'em and Norfolk had one farm outbreak and not multiple farm outbreaks that you've seen in other jurisdictions, because we put that effort into it. If you move it to the next level where we're controlling that through hotels, I think your compliance increases and I think your risk decreases.
Thank you. That's all my questions. Thanks.
Member Van Passen.
Thanks, Madam Chair. I just want to say thank you to the members of the Ag Advisory Board. That we've got a bunch of community volunteers who, yeah, it is a very busy time of year for them, and I think they put together a well-researched document that offers like realistic solutions. Not all of them may be agreeable to the Board of Health, but at least they're not just complaining about what they don't like. They're offering real solutions that are based in, you know, fact and scientific research and all those kind of things. And I'm sure there are some of them that I'm sure that the Health and Social Services would be more than willing to implement, like especially like that idea, the team idea. I guess they call it the cohorts, where you say certain individuals stay in one part of the bunkhouse together, they work together, and they don't mix with the other ones. Those are the kind of good ideas that we're looking for to try to make it work. So again, I just want to say thank you to the members of the Ag Advisory Board for going to the effort and bringing realistic proposals to the table, not just pie in the sky dreams. So thank you.
Questions from the board? Okay, thanks, Jason. Go ahead.
I just want to have one final comment. I would agree with Councillor Van Passen. I know I've asked Councillor Van Passen and Councillor Columbus, who is the official council member for that board. We've had a few unofficial meetings with farm representatives. You know, I would say that we are working together. We might not always agree, and that's life, and you don't always agree. But by having good discussions and by working towards a solution, I think that's effective. So I would echo Councillor Van Passen's comments that you know, we are trying to work together. They are, as both of you said, this is a busy time of year for them. Our meetings sometimes are at night and later at night, but we are trying to work to it. And I think this is going to be an issue not just for this year, but for next year also. And I think we need to start getting ahead of next year because it's going to come soon. And I will echo those comments. I do thank the AAB, and I look forward to many more meetings with them.
Shanker, did you have any comments on this, or?
So, Matt, through the chair, I think that there are many opportunities to improve and work together. You know, I've spoken to a number of farmers over the past week, and in my presentation we'll talk a little bit more about cohorting and other strategies to try to help with containment with COVID-19. So I look forward to that dialogue, and hopefully I'll have a chance to speak to it shortly.
Wondered actually if I could just come back to Councillor Columbus, your question about the hotel and what happened with that. And I just think, and Shanker could maybe touch on this better, but I think that there's often a misconception that's out there, that is that if you do your 2 weeks, that means you're good. But if it's 2 weeks from the point of time that you begin exhibiting any symptoms. So if you didn't begin exhibiting symptoms until day 8 or day 9, you are still supposed to quarantine for a further 2 weeks. And I think that's where, when there's this, you know, discussion, well, they did their 2 weeks in quarantine in the hotel, and therefore they must have all been fine when they left. That's not true, because if they hadn't disclosed, or if they had disclosed those symptoms, 2 of those individuals would have been in the hotel for more than a 2 week period. Did you have anything on that, Shanker?
Yes, you know, the self-isolation period is an opportunity to burn out the virus. So if you come in with the virus and you don't have any symptoms, after 2 weeks, you'll burn it out. If on day 5 you start coughing and have a fever, it's really important for that information to be communicated, because then your self-isolation period extends from the first date of your symptoms. I think that when we think, like in everything in medicine, we learn from the outbreaks, right? One of the issues is that workers, how the inquiry happened related to their symptoms. is some area of improvement. Some people choose not to disclose their symptoms because they're fearful they'll have a loss of income. Some people the inquiry is not in their language or in a way that they understand. The person who makes the inquiry will be more likely to yield symptoms. And we found this during the outbreak, where when the managers of the agricultural enterprise inquired about somebody, the answer was no, I didn't have any symptoms. When a member of the nursing team inquired, they said I did have symptoms. And one of the things that we do know from this outbreak is people were working when they were sick. And when they were working when they were sick, they're more likely to end up at the hospital later in the course of their illness. So, the fact that we have, I think, 2,400, I have the numbers here, we have about 2,400 migrant farm workers. We've had one outbreak, and that outbreak is going to come to a conclusion shortly. In Windsor, Essex, and I know they're working hard in Windsor, Essex, they have, I think, 26 farms that are affected. So the only way we'll know how successful we were from a public health management point of view is to wait the year out. But I think that when we think of this as a risk, we have to really try to manage risk as best as we can, recognizing that some of these items are uncertain. 6 months ago, I never heard of COVID-19, and it's my 30th year of practice. And when we put in our program in March, we anticipated challenges, and we know now more in June than we did in March. So I would say that burning out the risk is probably the most viable public health policy we have. Hoping that somehow we can effectuate social distancing in a bunkhouse, I think that is highly unlikely, because one is there's 80 square feet allocated for every person, and that includes the bed. Secondly, the bathrooms and bedrooms are shared. I mean, the bathrooms and kitchens are shared. And those are places even that people don't typically wear a mask. So even if you were to argue for PPE, if you're coughing or engaging in other bathroom conduct or bathroom activities, it's likely that that's a vector of spread. The other thing to think about is once a case of COVID-19 gets into a congregate setting, be that a nursing home, and we know that from our own experience here, or in a bunkhouse, virtually everyone will get it. At the outbreak at the farm, of the 220 people who resided at the farm, 199 ultimately turned positive. So it's a risk we have to manage as best we can. I could talk about this topic forever, but maybe I'll just go on to talk at my presentation.
Okay, if I could have a mover and seconder that the communication item from Jason Burgess respecting the Agricultural Advisory Board's position on preferred practices with COVID-19 and management's response be received as information. Moved by Member Taylor and seconded by Member Rabbits. All those in favor? Carried. And Shanker, I guess if you'd like to begin your presentation.
Madam Chair, members of the Board of Health, thank you for allowing me to speak today. Just as a comment, the next time I'm here, I'd like to talk about opioids instead of COVID-19, but since this is the topic of the day, I'll chat about that. So the main goal of the Public Health Service is saving lives and advancing health. And it's advancing health just not on an individual level, the individual patients we see, but also on a community level, the 110,000 people we serve. And a big part of what we do in the Public Health Service is managing risk. And that's probably the most important part of our job on a population health level. So that requires us to identify, manage, and mitigate risk. I know I mentioned this before, but COVID-19 is a new disease. Many of the clinical inferences that we're making today are preliminary. So I presented this slide this way. This is from the Centers for Disease Control. And these are the symptoms that you might think people with COVID-19 present with. Some of them are really quite unusual. Loss of taste or loss of smell. Some are pretty common, like I'm not feeling well. And some are sort of atypical, nausea, vomiting, and diarrhea. I could tell you from our experiences in this health district, and we have 444 cases, fever without any other symptoms is probably the most worrisome of all presenting symptoms. This is a modern type of imaging. If you can believe me, this is one lung and this is another. These are the areas that are affected, these red spots by COVID-19. I put this out here not to gross anyone out, but this too is a feature of COVID-19. COVID-19 can affect the blood vessels, and as it affects the blood vessels, it can lead to clotting in the feet. And so when we think of COVID-19, it's just not a respiratory disease, it's a multi-system disease. I put this slide here to show us where the United States is and where our neighbors are. So this is the beginning of the epidemic. We had about 40,000 cases. This is today. There are 55,000 cases recently. So the Americans, it would appear, are on this metric aren't doing that well. There are 3 million, approximately 3 million people in the United States who've been infected, and there are about 130,000 people who have died. So it's more people than our health district. In Mexico, cases are increasing, they continue to increase. And in Mexico, they've had 30,000 deaths. Now, they're now the 5th highest country in the world for deaths for COVID-19. And the particular challenge in Mexico is they don't have good infrastructure for testing. So probably this is an underestimate of the risk. So where are we in Haldeman, Norfolk? Well, we had a big spike with the farm outbreak, but we're around 444 cases, and that stayed relatively constant. Where are we for age distribution? As you can see now that we have more younger people affected, we have people in their 30s and 40s, and that represents a distribution also of residents who live on the farm. I'm always asked about the question about Haldeman and Norfolk County. I always think it was one health district, but if we look here, the cases are pretty widely distributed, but these two clusters occupy a disproportionate number. The farm in Norfolk County and Anson Place in Haldeman County. So this is about the number of agricultural workers. There are 2,643 have arrived, 2,432 are here, 211 on self-isolation. There are 364 isolation plans approved, submitted, 97% have been approved. The public health inspectors work with farmers to try to get their plans approved. Sometimes that requires some level of creativity. You know, my job, the Public Health Service is apolitical. We're governed by the statute, and we're here to serve the 110,000 people who live in the district, and that includes people who reside on the farms. I put this in here because I guess this woman was brave to let someone take her photograph, but this is what a nasopharyngeal swab requires. It requires putting a long swab into somebody's nose. The reason I say this, and this is here, is that the test is not good. It's okay, but it's not good. So in some cases, it can miss 20% of the people. There's one paper I think I have here that says it might miss up to 30% of the people. So the test for COVID-19 is not like an HIV test. And it requires doctors and other healthcare practitioners to go back to the standard way of practicing medicine. Ask the patient, examine the patient, and treat and test them. And when you pull all those three data elements together, you can make a determination. Why do I say this? Because on occasion, we will arbitrate a case as COVID-19. So someone comes in from a foreign country, they're coughing, they have a fever, that country's endemic, they're early in the test is done, the test is negative. Well, if they have clinical symptoms suggestive of COVID-19 and they have the right presentation, we'll arbitrate it that way because we want to prevent the spread. In a congregate setting, one person could be the beginning of the entire congregate setting being subject to infection. I wanted to talk about this. We use this word outbreak assessment. In the Public Health Service, there are outbreaks and there are outbreak assessments. So an outbreak assessment is when we receive information of a possible communicable disease outbreak. It's not always COVID-19. In previous years, it was chickenpox, or it could be an influenza outbreak. But we make an assessment, and sometimes people report this, or we get a clinical suspicion. So we might hear from a school principal, we might hear from the emergency department, we might get the result of a laboratory test. So whenever we have an outbreak assessment, we get the story, we order the test, we trace and manage contacts. We know for COVID-19 The rule of thumb is 2 to 4 people might be infected with one positive case. And that's, so we spend a lot of energy trying to track people or contact people, and we advise the institution or the enterprise on how to prevent future outbreaks. So what are places that have had outbreak assessments? Well, long-term care facilities. I think on average we do about 30 long-term care facilities and retirement homes a year. Schools, daycare centers, and farms. And we are doing outbreak assessments in some of these facilities right now. So what have we learned from the outbreak in the farm? We've learned that 90% of the people ultimately tested positive who were in the residences. Once COVID-19 is introduced into a congregate setting, it's likely to spread throughout. That's also true in our experience at Anson Place. Managing an agricultural enterprise requires formulating, the managers have to formulate a safety plan. That's where we are in the outbreak now. We're reviewing the safety plan. This is something that's very concerning. There may be seasonal recurrent outbreaks of COVID-19, just like the flu. So then what? We really have to be vigilant. So if you get COVID-19 today, you probably have some level of immunity moving down the road. But at some point in time, you'll stop being immune, or it'll be like the flu. You'll get it a year. People can be at risk every year. And we really have to improve the medical care for all residents. We heard that from my colleague Kate today, but we also have to do that for migrant farm workers. Just as a summary, 220 people in the farm, 18 people were evaluated at the hospital, 12 were admitted at the hospital, 7 were admitted to the ICU, 1 person remains in the ICU, and 1 person has died. So that's sort of the outbreak summary as it relates to hospitalizations. I have had dialogue with farm operators, and we've had dialogue with this particular farm operator in outbreak. The first thing about a safety plan is it has to be individualized for every enterprise, because they are different. Some people have one residence at one site. Some people have 7 residences at multiple sites. Some people have indoor, growing under glass. Other people do not. There has to be some process for screening workers for early identification of illness. That can be questions. It can be a temperature setting, temperature measurement. There has to be access to personal protective equipment. There needs to be cleaning supplies, especially bathrooms and kitchens. There has to be some idea to effectuate social distancing as best that can happen. I'm going to talk about cohorting in a minute. There has to be avoidance of large groups. It's not unexpected that if you live in a bunkhouse that you might want to be engaged in a soccer match or a barbecue. That is a high-risk setting. There needs to be access to medical care, and there needs to have some strategy for testing some people. Testing in itself is not the resolution. It's about caring for people and caring for the institution and caring for that community. Outbreaks at farms are likely to lead to greater regulatory involvement of the federal and provincial agencies. I've been contacted by both federal and provincial agencies after the outbreak, and I expect there will be more surveillance and involvement of the regulators. Cohorting is one approach to managing COVID-19, and I'm going to talk about it in the farming context, and then I'll talk about it in the non-farming context. So just imagine if you have field 1 and bunkhouse 1 and field 2 and bunkhouse 2. And if people from bunkhouse 1 go to field 2 and people from bunkhouse 2 go to field 1, you have a larger group of people interacting. After the workday, they'll go back to the bunkhouse, the workers, and they'll have further spread of the virus. So cohorting is limiting or containment. It's to ask people who work in bunkhouse 1 to work in field 1, bunkhouse 2 to work in field 2. And that's the strategy for cohorting. We use this in hospitals, and in fact, we can use this for schools. So if teacher A and there's teacher B and they have classroom 1 and classroom 2, if in the afternoon they switch classes, there's going to be more interaction between the teachers and the group of children. And the teacher may become the vector of transmission. And if the child gets sick, he goes and sees his mother or father, and then it goes to the grandparent and may spread to other people in the community. So cohorting breaks the chain. It's one strategy to break the chain. I know one member of the Board of Health, actually, this was the funnest assignment I've had. COVID myths, I guess there are lots of them. So this is from the World Health Organization. Adding pepper to soup or other meals does not prevent or cure COVID. I guess that's circulating on the internet, but pepper doesn't have any real effect on COVID transmission. Spraying or introducing bleach or other disinfectants into your body will not prevent the transmission of COVID as well. So I close with this, and I know time is precious. This is Charles Mayo. He was one of the founders of the Mayo Clinic and the son of the original Mayo. The prevention of disease today is one of the most important endeavors in the line of human endeavor. And I think that was true when he died in the 30s, and I think it's true today. So with that, I'm happy to answer any questions. Thank you.
Thank you, Dr. Nastari. Any questions? Member Rabbits.
Thank you, Madam Chair, and through you. My question for Medical Officer of Health is about some of the information coming forward about the spread of COVID-19 beyond possibly droplet spread, but through aerosols or in the air. And I was hoping for some comments about that now that it's hit the mainstream, and I've seen it come out of some peer-reviewed articles, but now it's being discussed more. And I was wondering also, maybe as a secondary question, about the wearing of masks, now that it's become more of an issue depending on your jurisdiction, and there's even been mandatory mask regulations put in place for enclosed public spaces. And I was hoping for maybe just a comment about this virus moving beyond droplet spread to smaller particles, and some comments about whether masks should be made mandatory, or what the framework is in reviewing the use of masks and PPE in Haldimand and Norfolk.
So I think that, and thank you for those questions, I think that the medicine's never 100%. If it was 100, it's never 100%. Things that we thought were true in the past, we've sort of changed our mind, even in COVID. So when this all started, the general consensus was there's no asymptomatic transmission, meaning if you weren't sick, you were not likely to communicate it to anybody. We think that's probably not true today. I don't think the evidence is compelling that airborne, the WHO received communication from a number of clinicians. I think the evidence for airborne transmission is not well established today. And so I would say, based on the evidence we have, the wealth of evidence today, that airborne transmission is not likely. That position might change, but I think the evidence today suggests that it's not likely. With regards to masks, I think people should wear masks at any time which they cannot meaningfully socially distance. So when I go to the grocery store or when I go to Walmart, I would wear a mask. If I went to the auto body shop or the garage, I would wear a mask. The question of making it mandatory or not, and I get people on both sides of this calling my office. I've asked them for those people to make presentations to the council, because it's not that do I think masks work. I think masks have a role. They're not the panacea, but they have some role in preventing the transmission of COVID-19, just as much as burning out background risk, trying to isolate, test, contain, self-isolate people. So I think it's worth having that dialogue about I would encourage people to wear masks, but if it is mandatory, I think that's something that we need to have a broader discussion about and see if we can get more to a consensus on that item. But I do support wearing masks. I think it's a good thing to do.
Hoffman?
Thank you, Madam Chair. Has the Haldimand Norfolk Health Unit put a plan in place for the upcoming Potahawk event that will be occurring, I believe, this Sunday?
Yeah, This is go ahead, maybe Marlene can answer this.
Through the chair, if I may, I understand that through the EOC and different community partners, there is conversation on plans to address some of the concerns with Pottahawk.
Kind of vague. Could you expand on that?
I'm just not privy to all of those yet, so I can't comment right now. I don't know if Mr. Burgess is in the building that could expand on it further. I know that there has been dialogue related to that, and some recommendations from the public health have been put forward, but they were working on some of those strategies with the OPP, et cetera.
Pardon? Sure, thanks.
My apologies. Can the question be repeated? I was multitasking.
Yes, I was just wanting to get some information as to what the Haldeman Norfolk Health Unit and I guess our county has put in place for the Pottahawk event that is fast approaching.
Thank you. Through the chair to the board member, bylaw and OPP are trying to work together. We will be putting out some communications on the event. Of course, it's an unplanned, uncontrolled event, so we have so many limitations. We do have some issues this year. EMS will not be able to be in boats this year because of their respirators. If they get wet, they become useless. So we will not have EMS in boats. Because of the water levels, we won't be able to get too close to the area either, so we'll have to have additional measures put in place for public safety on that. We are hopeful that our communications, along with a strong OPP presence, and we are also hoping for, trying to phrase the right word to be politically correct, we hope people use common sense during this time to not participate in activities that could see a spike in it. And we will have, our bylaw can't do too much because of the location. We'll try what we can. We will market it. Matt has some communications going out on the matter, and the OPP will the OPP will enforce as they see fit on the water.
Did we approach the province at all for any additional funding to deal with this, I know, unplanned event, but unfortunately it does occur every year?
We did not approach for funding at this point in time. We have approached all reasonable authorities, including the Coast Guard, various ministries, on it to see what their input would be. There's very little uptake in any participation from any of the agencies. It would be my comment. So it's really the OPP is our best enforcement tool for this event.
Just to add further to that, Member Huffman, Mayor Hewitt and I both spoke as far back even as the phone call with the Premier, with the mayors, and our number one concern was enforcement of day trippers and issues down here, and that same concern was reiterated by almost every other mayor in cottage country areas. There was discussions of there being, that they would get back to us with what they could do to provide some additional assistance, and there's been nothing come. Further, Member Martin.
Thank you, Chair Chop. To Mr. Burgess, if you're still there, I would appreciate any of the EOC information that gets solidified to trickle its way down to all of the Board of Health members, especially, I'm sure, Councillor Van Pass and Michelle and myself, as well as staff in the marina or marinas for the weekend, because I've already had questions about it myself and I have no information to share. Thank you.
I guess one of the potential things that could be up for discussion with the Board of Health was whether you wish to restrict the boat ramp being used over Potahawk weekend, given that's where a number of challenges arise.
Again, no information in front of me to discuss what that looks like for the county, what the plans are from the county. I'm not prepared to make that call.
Through the chair, you know, we would certainly take direction from it. You could also take a look at the county does hold 2 resources also for boat launches, and whether you wanted to restrict the use of those 2 boat launches over the weekend. That's something the county, the council can direct county staff to do directly. Won't necessarily solve the whole problem, but could reduce it.
So to be clear, it's not something that has been discussed at EOC. It was just a suggestion now. I don't think that that's a move for staff to make on their own of closing boat ramps. I can imagine how that would go down. So it's just an idea that's being presented here now to the Board of Health in the event if they wish to restrict the boat accesses for this weekend.
Madam Chair, maybe I just don't get it, but you want to maintain social distancing, you restrict the boat access, that increases it, because the same number of boats will go in the water, they will just go somewhere else. So you shut down one, that means twice as many go somewhere else. So the more access points you have, the better it is. Again, maybe I'm stupid or naive or whatever you want. Well, stupid probably works best, but you gotta have some faith in people. It is social distancing. A boat is a boat. Stay on your boat, don't go on other people's boat. Enforcement, heard lots of talk about how many warnings have been issued over the last 3 months, but I still haven't got a big update on how many tickets have actually been written. You start banging $800 tickets in people's laps, they might listen a little bit better if they're not following the rules. And, you know, this is an unorganized event. It's just something that happens, and people that want to make it happen will do that, and you can put all the roadblocks in the way you want, or you can try to make it the safest event possible, whichever way you want to play the game. But, you know, it will be there, whether it's one boat or whether it's 1,000, and there's not much we can do about it. So let's work with that and try to make people aware that we trust them, they have brains, it's about time you use them once in a while. So I'd leave it at that. So.
I agree with you. I was just putting the suggestion out there. There's being questions as to what's being done, but there's very limited amount that Norfolk County can do. We don't patrol the waters, so you know those are the points that we control. So I just post Potahawk. At least we've put it on the table now, so it doesn't come back. Well, why didn't staff close the boat access? So I'm comfortable with moving on from there, unless somebody has another comment to make. Okay. In that case, if I could have a motion to receive the Medical Officer of Health's update, moved by Member Taylor and seconded by Member Rabbits. All those in favor? And that's carried. And the next item on the agenda, I believe, is the notice of motion. Member Columbus?
Yes, I wanted to speak to that. This notice of motion was actually primarily put together by Councillor Martin, and being I'm on the Ag Advisory Board, she gave me the privilege of putting it forward. And the way it reads is that the rules of order be waived to allow a notice of motion to be considered directly as a motion, and that the Board of Health direct the Health Unit to undertake consultation with representatives from the Norfolk County Agricultural Advisory Board prior to implementing any substantive program or service changes impacting the agriculture community, and that health unit staff be required to provide routine updates to the Board of Health upon consultations with the Norfolk County Agriculture Advisory Board. One of the things Mr. Burgess has been communicating significantly with the Ag Advisory Board, but when you think about the Ag Advisory Board, they are a creature of Norfolk County councilors. They are not a creature of the Health Board. So there's a difference there that has to be rectified. So we need greater communication and cooperation to kind of get on the same page. We heard from Mr. Burgess earlier, where we are not there yet. Hopefully we'll get there. And the big issue for the Ag Advisory Board was the fact that the 3-person per bunkhouse rule has really stymied the agriculture community when it comes to, I guess, primarily the economic livelihood of our farmers and the mental anguish that they're going through with the Section 22 order. And agriculture is a major economic driver here in both Haldimand and Norfolk County. And the AAB fully supports that we need greater communication, and I ask that the Board of Health members support this motion, which basically indicates that we need to communicate and consult greater to make the right thing happen. I'll let Councillor Martin perhaps has comments as well.
Through the chair, you've echoed, or you've already made a lot of the comments. I think that I would just add to that this came about after being invited to attend an AAB virtual meeting, and the reoccurring theme was having more dialogue and discussion. I spoke with Mr. Burgess. He had mentioned that it was already happening and underway, so I think this is a great way to just solidify that. I can think back to earlier this year, we had some media comments that weren't beneficial to Norfolk County Council or to the ag community. There was, the presentation we received tonight, and we heard Mr. Burgess speak about looking at some of the same troubles for next year. So I think this is a great way to have ongoing dialogue with the health unit and the AAB. And additionally, on their end, they plan to just have a standing spot on their agenda for health unit comments and updates to discuss regularly so that they're ahead of the curve. So that's all, and thank you, Board Member Columbus.
Okay, I have a motion that's been moved by Member Rabbit, seconded by Member Martin, that the rules of order be waived to allow notice of motion to be considered directly as a motion. All those in favor? And that's carried. And the motion reads as follows. Moved by Board Member Columbus, seconded by Board Member Martin, that the Board of Health direct the Health Unit to undertake consultation with representatives from the Norfolk County Agricultural Advisory Board prior to implementing any substantive program or service changes impacting the agricultural community, and that the Health Unit staff be required to provide routine updates to the Board of Health upon consultations with the Norfolk County Agricultural Advisory Board. Any further discussion on that? Member Michelli.
Thank you, Madam Chair. This question to the mover and the seconder, if they would be willing to consider a friendly amendment in the third section of the notice of motion to provide routine updates. I'm just considering the fact that very little during COVID-19 are routine things. I wonder if you would be willing to make that more specific, as in monthly, bi-monthly, weekly, some specific time period.
Well, it certainly is a good point. And right now, for the Ag Advisory Board to be meeting during this extremely busy time with harvest approaching, they may not be meeting quite monthly, but the executive perhaps will. I don't have a problem with that if the seconder supports it, whether it's monthly or bi-weekly, but like I say, there may not be meetings as quick as, try to get everybody together as quick as we want to.
My understanding was that we would just get the chair of the AAB to connect with a preferred staff member in the health unit, and he would connect with them when the agenda was being built. So he would certainly give our staff as much notice as possible, but I think that if this motion passes, we would then get them connected into staff and leave it up to that key staff member to find a working schedule between the two of them that was compatible for both of them and not restrict them to having to do it at certain times due to harvest and so on. That's why it reads as routine right now.
Thank you, Councillor Martin. That explanation, I think, clears that area up for me. I think that sounds like a very workable plan.
Okay, Member Taylor.
Thank you, and through you, my question would be if, just with how immediate things tend to happen during this COVID crisis, if a substantive change is going to be happening in the implementation of the program, how many members of the advisory board are we wanting staff to meet with before making that change? It would be, again, we know how busy the farmers are during this time. If there's a change happening and it takes 2 or 3 weeks to meet that threshold to meet with everyone, I just want to make sure there aren't any hiccups.
I was going to leave this until the end, but maybe I'll jump in now. I think it's important to note the following, that, Dr. Nesathari has a variety of obligations, responsibilities, and powers under the Health Protection and Promotion Act. And in particular, in the case of a contagious disease, he has broad powers under Section 22 of the Act, where he's granted the power to require a person to take or refrain from taking any action specified in his orders in the respect of a communicable disease. So, while, this motion is a feel-good thing, and I think it's great to further develop that relationship with the Agricultural Advisory Board, I think it's important for the Board of Health to note or understand, however, that there is no council resolution that can conflict with or override a provincial statute. So he would still retain that power regardless of this resolution. Member Martin.
That's through you, Chair Chop. That's not the intent of the motion. It's to get a seat at the table, have a voice, work on joint press releases, maybe work together, as opposed to having media comments that went out very early on in COVID that were not compatible. So it's to keep a seat at the table, work together. It's not intended to override any orders. And additionally, Dr. Nesathari is quite busy. If there's a suitable staff member that's working on a file that can provide an update to the chair, I don't think the entire Ag Advisory Board intends to meet with health staff and draw on their resource either. It does read consultation with representatives, so that could be just simply the chair or vice chair, a phone call to the health unit staff.
Right, thank you.
Member Rabbits.
Thank you, through you. My question might be a little bit more procedural in terms of, as board member Columbus has specified, the Agricultural Advisory Board is a creature of Norfolk County and not necessarily the Board of Health. And, I'd be interested as a board member of the Board of Health in receiving minutes as it relates to the health unit staff working with that advisory board at this table. And my question, I guess I'm trying to pose it as I go along here, is, what does that look like? What sort of feedback are we looking for at this table where we are making decisions, albeit in a constrained manner due to COVID-19? But, what information is coming back to us here? Is it the meeting minutes of that standing item when we have health unit staff either reporting on a topic or engaging with a chair? I appreciate that it says with representatives, so from my interpretation of that, Board Member Taylor, that it doesn't necessarily need quorum. You'd be working individually with those that are available at the time, just to keep that advisory board informed prior to major changes taking place. So I'm very supportive of the motion, but I'm looking for what to expect at our next Board of Health meeting. What's coming back from that advisory level? Are we to expect that standing item to receive some minutes from that? It'd be nice for us to know what staff members were present, what information was delivered. And I think it'd be a good, maybe even a consent item or an information item on our Board of Health agenda. So I'm thinking I'm directing this question towards our staff members who would be present at those meetings should this motion pass, of what they think the reporting relationship looks like to this board.
I think the deputy clerk has a response.
Through the chair to the Board of Health. That's a really good question. So when we were in coming up with an answer for your question, we could do it two ways. Our Board of Health could be structured with subcommittee minutes, so we could have kind of a report of a subcommittee and we could put it on that. Or we could put it under communications. So certainly we could take the direction and at least to allow this body to receive the minutes of the subcommittee, that's no problem. So again, we could put it on either way.
Go ahead.
Yes, we, in the past few weeks, we've had some informal discussions with Mr. Burgess. We called it basically a working group, but there was not much formality with respect to minute taking and that type of thing. But if Councillor Rabbits wants, we can kind of more formalize the process if staff's present in that and get more feedback to the Board of Health.
If I may respond. Absolutely. Like the information that we received this afternoon from Mr. Burgess, I found very informative and beneficial, and I think that's the type of format that I would be expecting, not necessarily an overly formal or bureaucratic way of reporting in terms of minute taking and things like that, but I'd like to know what the key points were, the high-level takeaway from those discussions, and it would be beneficial also just to know who is having those discussions. If I wanted to have any poignant questions towards a staff member, I know who they are and what content they're discussing or at what point they're joining the meeting. That sort of thing is, I think, what I'm after.
Member Martin.
Through Chair Chop to all of Board of Health, I think the intent was really to allow the chair to just not take up considerable resources from health unit staff, but have a standing call while the agenda was being built for the Ag Advisory Board, get any updates sent to them in writing, and then put it onto their agenda, at which point I think Steph's suggestion is great, that if those minutes from the AAB can just be included as communication here, and then that way it's not a presentation from staff if they're busy and whatnot, but at the end of this, should it pass, if a staff member could just be connected with the chair has a system in place at how it would work, and I think great point in just having the minutes shared.
Anything further? Let's call the vote then. All those in favor? And I just want to thank staff for all the consultations that have been going on with the Agricultural Advisory Board. I know an enormous amount of staff time and resources have been dedicated to that. Finally, moving on to other business. Is there any other business? Okay, in that case, I have Member Michelli.
I'm sorry, Madam Chair, are you referring to general announcements?
For the procedural bylaw of the Board of Health, it was not changed, and it's actually called other business still. But whichever, same thing,
Okay,
just a different term.
I'm sorry, Madam Chair, I'm just looking at the change to the agenda. It says that there will be item 11, the addition of general announcements.
I read it differently with the correction that I verified with the clerk to begin with. Okay. So at the beginning of the meeting, I stated other business, but it really, in reality, is the same thing as
okay.
General announcements.
So would I be allowed to make an announcement then? Or
absolutely, yeah.
Thank you.
Yes.
Thank you. I just wanted to mention that I just want to give kudos to our bylaw department and our bylaw staff for some of the enforcement of the COVID-19 protocols this past weekend. I know Board Member Van Passen mentioned earlier, about the number of charges. There was a significant charge for a mass gathering on a property in Long Point this past weekend, and I think that there was a significant amount of very valid enforcement with regard to social distancing and physical distancing. So I just wanted to give kudos out to our entire bylaw enforcement staff.
Anything further? Okay, in that case, motion's moved by, he's not here anymore, so if I could have a mover for the confirming bylaw, Member Taylor, seconded by Member Geisens, That bylaw 2020-08BH being a bylaw to confirm the proceedings of the Board of Health for Haldeman Norfolk Health Unit at this Board of Health meeting held on the 7th of July, 2020 be approved, signed by the Chair and County Clerk and affixed with the corporate seal. All those in favor? And Board of Health is, motion's been moved by Board Member Rabbit, seconded by, seconder again, Board Member Taylor. The Board of Health meeting for Tuesday, July 7th, 2020 adjourn at 4:32 p.m. All those in favor? That's carried, and let's reconvene at, to take 8 minutes here, 4:40. We do have people that are waiting for the public health meeting that was meant to start at 3.
Oh, and are you there?
All right, 4:40, if we can get going. Good afternoon and welcome to the Public Hearing Committee meeting for July 7th, 2020. I'd like to remind everyone that our meetings are web streamed and televised. And for those in attendance, if you could please put your phones on silent mode. Any disclosure of pecuniary interest? Okay, seeing none, I now officially open the public meetings held under the Municipal Act and the Planning Act for the purpose of hearing applications and proposals and affording any persons in attendance the opportunity to make representations to the Public Hearing Committee. A reminder to those addressing the Public Hearing Committee electronically to please state your full name and address when you're called upon. Those speaking on planning matters, please be advised that to preserve your right to appeal to the local planning appeals tribunal, you are required to make comments or provide submissions prior to the passage of a bylaw. A reminder that the Public Hearing Committee will receive the staff report for information and hear from the public on the application. Staff recommendations will be before Council at their next regular meeting along with the bylaw. Speakers are limited to 5 minutes unless they are the applicant or the planner, in which case we will provide some leeway to present their application. Speakers, please also be reminded that information presented cannot be repetitive in nature. First report is staff report PD 20-33. This is an application that has been received to permit an accessory dwelling unit as part of an on-farm diversified use that is located more than 30 meters from the primary residential dwelling. Lisa Dove, on behalf of Harold Dove and agent C. Jagger Designs, have put forth the application affecting the lands described as 283 Lynn Valley Road, Norfolk County. And Tricia, I guess, for you to present. Welcome.
Thank you. And good afternoon, everybody. So I'll be presenting both reports today, although both these reports were written by one of our new planners, Fabian Serra. He is on the call virtually somewhere, so he is here. But I'll be presenting as indicated. So this application, as already presented, was submitted by C. Jagger Designs on behalf of the property owners for permissions related to the establishment of an accessory residential dwelling to be located above the on-farm diversified use. The property is, it's not working. There we go. Thank you. The property is located on the north side of Lynn Valley Road in the former township of Woodhouse, and there is an existing residence and 2 farm structures on the property, and the property is being actively farmed. So this application was first filed last year and was deferred to wait for the county-wide zoning bylaw amendment, which expanded the accessory dwelling units to be permitted in other zones beyond the urban residential, and to also permit those accessory units to be located in accessory structures. So following the approval of that countywide amendment, this application was revised to address two deficiencies because they didn't meet those provisions. So one was related to allow the secondary dwelling unit to be more than the 30 meters. And the second piece was to allow for the secondary residential unit to be larger than the 45% gross floor area. And the rationale for this secondary unit size was because a portion of the on-farm diversified use, so the office space, was going to be incorporated into the residential use. And so the rationale was to allow for that larger secondary residential from 45 to 75%. The only comments that were brought to our attention through Parks and Recreation, specific to the location of the property, you can see that it's proposed to be in a forested area. So the proponents were provided with the Forest Conservation Bylaw and explained about the permits and approvals process for that location. No comments were received from members of the community. So with that, I'd be happy to answer any questions.
Thank you, Tricia. Any questions from the committee? Councillor Rapids.
Thank you, Mayor Chop. Through you, I'm just looking at the recommendation. It says to receive the report as information. Are we looking for approval, or is this just satisfying the public notice portion of the development?
Thank you. Yes, through the chair. So my understanding is a couple months ago we changed the process. So this is the statutory public meeting, and then the report will be coming back July 22nd.
This was the change that we made in the process.
Yeah.
We have had several meetings this way. I just think that we've had a break for a long time from the public hearing. So that was the challenge before, was we were receiving the public input on the same night as we were approving, when in reality, staff should be taking the public input and, incorporating that into the final report, which will be presented to council for approval. Further questions? Councillor Columbus?
Yes, thank you, Madam Mayor. Will this property, the upstairs is going to be residence, the downstairs is going to be commercial. Will it be taxed as a business, or will it be receiving a farm type of tax?
Through the chair, that's a good question. It's an on-farm diversified use. I'm not sure how MPAC would assess it. Probably as some, there will be commercial use on the ground floor, so that would be my expectation, but I don't know for sure.
Okay. And the 74 acres, is it rented out, or is it farmed actively by the current owner, Mr. Dove?
Through the chair, my understanding is it's actively farmed by Mr. Dove.
Thank you. That's all I have for now. Thanks.
Further questions from committee members? Okay, is the applicant or agent wishing to speak? Okay, is there anyone participating?
Hi, it's...
Go ahead, welcome.
Sorry, thank you. My name is Caroline Jager from C. Jager Design. Address is 524 St. John's Road, East Port Dover. I don't have much to add. Tricia did a great job. This application is just for Ms. Dove to move her business back to her home farm and hopefully continue there.
Okay, thank you. Is there anyone else participating electronically that wishes to speak in favor of the application? Is there anyone participating electronically wishing to speak in general or against the application? Is there anything further from the public hearing committee? Go ahead, Councillor Columbus.
Yes, I've got a question for the applicant, or perhaps the planner. How many acreage of flowers will you be producing at this particular property?
I believe that's in my hands. This is Lisa Duff, 1567 Old Brock Street in Victoria. The intention is to start out with a small amount to see what I'm capable of. So it's not going to surpass anything beyond like a 3-acre option. If I can get there, I can dream.
Okay, I didn't quite get that, but I take it you'll be probably purchasing the flowers in to your operation versus?
Yeah, so I currently have a wholesaler who supplies to me, and I also purchase locally from our local farms. But the intention is to actually grow some product on the property, depending on what flowers are conducive to the soil conditions that are there.
Thank you. Madam Mayor, I have one more question for the planner. And we have a surplus dwelling policy, Tricia. And after 10 years, a property, a house can be severed. So how would this, I know it says that severances to separate on-farm diversified uses from the farm property will not be permitted, but 10 years down the road, it could be permitted because it actually could be surplus farm dwelling. Any comments?
Thank you. Yes, through the chair, and thank you for the question. So this is a secondary use, and it's explicitly stated in the bylaw as drafted and as the proponents had seen that this will be a secondary residential dwelling, so it will never qualify under that severance policy because it would never be the primary dwelling.
So that would be noted on file or at the registry office?
It will be in the zoning bylaw and in the explanatory notes.
Good, thank you very much.
Further questions from committee members? Okay, if I could have a mover to receive PD 20-33 as information, moved by member Martin, seconded by member Huffman. All those in favor, councilors, my apologies. All those in favor? Carried. And next staff report is PD 20-34. This is Norfolk County has initiated an application to amend the official plan and zoning bylaw to recognize existing government offices as permitted use and to bring the existing use into conformity with the Norfolk County official plan and zoning bylaw. John Aarons, agent from IBI Group, on behalf of Nick Rizzo, Michael Rizzo, and Victoria Johnson, have put forth the application affecting the lands described as 12 Gilbertson Drive. Is the applicant or agent available? Did you wish to speak to this, Tricia? Is that how that's okay?
Thank you. So just to give some context, this is one of a variety of applications that are carried over. So we're trying hard to kind of clear existing files that have been hanging around for some time. So we are no longer retaining the services of IBI Group. We're just bringing this forward as a housekeeping item to clean this up. So this application is specific to 12 Gilbertson here in Simcoe, known to staff as GAB, the GAB Administrative Building. And the purpose of the official plan amendment, sorry, I can't seem to, there we go, thank you. The purpose of this official plan amendment and zoning bylaw amendment is to bring the existing government office into conformity with the official plan and zoning bylaw. Within the building, as people know, there's health and social services, GIS, the training lab, archives, and document storage. And there is an existing site-specific zone for the property. The office space started in 1997, and so it's existed prior to the official plan and current zoning bylaw. It is a legal non-conforming use. My understanding from reviewing the file was the intention was to bring this structure into conformity, and that's why they brought this application forward. So it's simply for the official plan and zoning bylaw to recognize the existing use as expanded, and nothing beyond that. So with that, I can answer or attempt to answer any questions.
Questions from the committee? No questions. Okay. Is there anyone participating electronically wishing to speak in favor of the application? Is there anyone participating electronically wishing to speak in general or against the application? And is there anything further from the public hearing committee? Okay. Can somebody move a motion to receive the report as information? Moved by Councillor Taylor, seconded by Councillor Rabbits. All those in favor? And that's carried. And finally, if I could have a motion that the public hearing committee meeting of July 7th, 2020 be adjourned at 4:53 p.m. Moved by Councillor Huffman and seconded by Councillor Rabbits. All those in favor? And that's carried. Great night.